Hi everyone, welcome back to ISC Psychology. Today, we will focus on mood disorders and personality disorders from your psychological disorders chapter. Pay close attention to the causes, symptoms, and types of mood disorders, as they often appear in case study style questions in exams and can be easily confused if not learned properly. I will include important exam tips and discuss where students lose most marks in exams and common mistakes to avoid. So follow along. Mood disorders and personality disorders are different from anxiety disorders in an important way. Mood disorders are about disturbances in emotional state, while personality disorders are about long-standing, deeply ingrained patterns of thinking and behaving that shape how a person relates to the world. We look at severe depression and bipolar disorder first, then move on to three personality disorders: antisocial, avoidant, and dependent. Severe depression goes far beyond ordinary sadness. It is a persistent, pervasive low mood that significantly interferes with a person's ability to function. The core characteristics include a persistently low or sad mood and a loss of interest or pleasure in activities the person previously enjoyed, a symptom often called anhedonia. This is often accompanied by changes in appetite and weight, disturbed sleep, either insomnia or oversleeping, fatigue and loss of energy, feelings of worthlessness or excessive guilt, difficulty concentrating or making decisions, and in severe cases, recurrent thoughts of death or suicide. For a diagnosis of severe depression, these symptoms need to persist over a significant period of time and cause real impairment in daily functioning, not just one bad day or one bad week. So, important thing to remember is that do not write the person feels sad for severe depression. Examiners are looking for the full cluster of characteristics, including mood, physical symptoms, cognitive symptoms, and the duration or impairment. A one-line answer will not give you full marks. The second mood disorder is bipolar or manic depressive disorder. Bipolar disorder is fundamentally different from depression alone because it involves cycling between two opposite emotional states, mania and depression. This is the most important distinguishing factor for your exam. Bipolar disorder is not just very low mood, it is the presence of both extremes. So, what is the manic episode? During a manic episode, a person shows an abnormally elevated, expansive, or irritable mood. This is accompanied by inflated self esteem or grandiosity, a decreased need for sleep, being unusually talkative, racing thoughts, being easily distracted, an increase in goal oriented behavior, and often engaging in risky or impulsive behavior, like reckless spending or risky decisions making without considering the consequences. The depressive phase of bipolar disorder shares the same characteristics we just covered for severe depression: low mood, loss of interest, changes in sleep and appetite, fatigue, and feelings of worthlessness. The most common mistake here is treating bipolar disorder as just a more severe form of depression. That is not correct. This disorder is defined by the cycling between mania and depression. If an exam question describes a person who feels sometimes extremely energetic, impulsive, and needs little sleep, and at other times deeply depressed, that is your cue to identify bipolar disorder, not depression alone. Before we look at the three specific personality disorders on your syllabus, it is worth slowing down on understanding what makes something a personality disorder, rather than a mood disorder or an anxiety disorder, because this distinction shows up constantly in how exam answers are structured and marked. A personality disorder is an enduring, pervasive pattern of inner experience and behavior, covering how a person thinks, feels, relates to others, and controls their impulses, that deviates markedly from what their culture expects. The key word over here is enduring. Mood disorders like depression and anxiety disorders like phobias tend to be episodic. They have an onset, they fluctuate in intensity, and with treatment, they can improve or go into remission. Personality disorders are different. They are stable, long-standing patterns that are usually recognizable by adolescence or early adulthood, and they show up constantly across a wide range of personal and social situations, not just in one context or during one difficult period. There is another subtle but important distinction worth understanding. Someone with depression or an anxiety disorder usually feels that something is wrong. Their symptoms feel foreign or distressing to their sense of self. Personality disorders often don't work that way. Because the pattern has just been present for so long, it can feel just like who I am to the person experiencing it, even when it is causing serious problems in their work or emotional life. That's part of why personality disorders can be genuinely difficult to treat. The person isn't necessarily experiencing their own traits as a problem, even when the people around them clearly are affected by them. Antisocial personality disorder is built around one central theme: a pervasive disregard for and violation of the rights of others. This pattern typically has roots going back to childhood or early adolescence, and diagnostically, it's often preceded by conduct disorder, a pattern of childhood behavior involving rule breaking, aggression, and a violation of others' rights. Deceitfulness is one of the core symptoms. This is not occasional dishonesty, but a period of repeated lying, using false identities, or conning others purely for personal profit or pleasure. Impulsivity shows up as consistent failure to plan ahead. Decisions get made in the moment, without regard for consequences. Irritability and aggressiveness often manifest as repeated physical fights or assaults, not just short temperedness. There is also a reckless disregard for the safety of both others and themselves. This might look like dangerous driving, substance misuse, or other high risk behavior undertaken without concern for the danger involved. Consistent irresponsibility appears across major life domains. Repeated failure to sustain steady work or to honor financial obligations like debts and support payments. And perhaps most distinctively, there is a marked lack of remorse. The person tends to be indifferent to having someone hurt, mistreated, or stolen from someone, or will actively rationalize it rather than feeling guilt. For example, picture a colleague who repeatedly takes credit for others' work, lies without hesitation when confronted, and shows no discomfort or guilt afterward, even when directly shown the harm they've caused. That combination of manipulation plus an absence of remorse is one of the clearest real world signatures of this disorder. The causes of this disorder are best understood as an interaction between biological vulnerability and environmental exposure, rather than one single factor. On the biological side, there is evidence of genetic predisposition. Antisocial personality shows up elevated rates among first degree relatives, along with research suggesting under-arousal of the autonomic nervous system in some individuals, which may explain a drive towards risk-taking and simulation-seeking behavior as a way of reaching a normal level of arousal. On the environmental side, harsh, inconsistent, or neglectful parenting during childhood is a major contributing factor, especially when combined with inconsistent discipline, alternating between severe punishment and no consequences at all. A childhood history of conduct disorder is considered a key developmental precursor, and broader environmental and social cultural factors like exposure to family conflict, community violence, or association with deviant peer groups during adolescence further increases risk. A very common error is only writing symptoms and skipping causes entirely, or vice versa. Since your syllabus specifically asks for both, examiners especially split marks between the two. A symptoms only answer usually caps you at half marks. When you write causes and try to cover more than one category, so biological and environmental, rather than listing several examples for just one, you will earn more marks. Next, we come to avoidant personality disorder. This looks almost the opposite of antisocial personality disorder. Instead of disregarding others, the person is intensely, often painfully afraid of them. But it's important to be precise about what that fear actually involves. This is not someone who simply doesn't want to be social. It is someone who wants connection, but whose fear of criticism, rejection, and humiliation is so overwhelming that it constantly overrides that desire. The symptom picture centers on social inhibition, deep and persistent feelings of inadequacy, and hypersensitivity to negative evaluation. This plays out across several areas of life. Occupationally, the person tends to avoid jobs or activities that involve significant interpersonal contact, not because they lack the skill, but because they fear criticism, disapproval, or rejection from colleagues. Socially, they are unwilling to get involved with people unless they are certain of being liked, which in practice means that they hold off from forming relationships that most people would enter more freely. Even within relationships, there's often a restraint or guardedness driven by the fear of being ashamed or ridiculed. They tend to be preoccupied with being criticized or rejected in social situations, replaying interactions and scanning for signs of disapproval. In new interpersonal situations, they often appear inhibited, view themselves as socially inept, personally appealing, or inferior to others. Causes for this disorder are typically a combination of an inborn temperament and specific life experiences that reinforce it. Temperamentally, many individuals with avoidant personality disorder show behavioral inhibition from very early childhood, an innately shy, very cautious disposition that's observable well before school age. This temperament tends to interact with the environment. Early experiences of rejection, harsh criticism, or conditional acceptance from parents can teach a child that they are only valued when they perform a certain way, or that expressing themselves invites disapproval. Peer experiences matter too. Rejection, ridicule, or bullying during childhood and adolescence, especially targeting appearance, competence, or social standing, can deeply reinforce a fear of negative evaluation. Plus, there is a biological predisposition towards heightened anxiety in many cases. An important exam tip: students often confuse avoidant personality disorder with introversion or shyness. The key distinguishing feature is that the intensity and the underlying motivation. It is not a preference for solitude, and it is not that the person does not want relationships. It's a fear of rejection that is so strong that it actively limits their occupational and social life, despite genuinely wanting connection. Finally, we come to dependent personality disorder, which centers on an excessive, pervasive need to be taken care of, a need so strong that it leads to submissive, clinging behavior and a persistent fear of separation from the people the person depends on. Where avoidant personality is driven by the fear of others, dependent personality is being driven by the fear of being without others. The symptom picture shows up more clearly in decision making and self reliance. The person has real difficulty making even everyday decisions, like what to wear, what to eat, how to spend their day, without an excessive amount of advice and reassurance from other people. They tend to need others to assume responsibility for most major areas of their life, effectively handing over control of everyday decision that most adults would make independently. Disagreement becomes genuinely difficult to express, not because they lack opinions, but because of a fear of losing the support or approval of the person. This goes well beyond a realistic fear of consequences. It is a deeper anxiety about the relationship itself being at risk. Starting projects or tasks on their own is difficult, again, not from a lack of ability, but from a lack of self confidence in their own judgment. They will often go to excessive lengths to obtain nurturance and support from others, sometimes even volunteering for unpleasant tasks just to secure that ongoing care. Being alone tends to bring real discomfort or a sense of helplessness. And when a close relationship ends, there is often an urgent need to scramble and find a new relationship as a source of taking care of and support that they've lost. Causes center heavily on early relational patterns, overprotective or authoritarian parenting styles, where a person's or a child's independent decision-making and autonomy are consistently discouraged and overridden, are a major contributing factor, since the child never gets the opportunity to build confidence in their own judgment. Chronic physical illness or periods of genuine physical dependency in early childhood can also contribute, since prolonged reliance on caregivers during a formative period may generalize into a broader pattern of dependency later in life. An insecure attachment style, or an anxious or ambivalent attachment formed in infancy, is also strongly associated with this disorder. Finally, a reinforcement history matters too. If dependent, help-seeking behavior is consistently rewarded with attention and care in childhood, while independent behavior was discouraged, ignored, or even punished, that pattern is likely to persist into adulthood. One important tip: in case study questions, students often mix up dependent and avoidant personality disorder because both involve social difficulty. The distinction is that avoidant disorder is driven by a fear of rejection and criticism, while dependent is driven by a need for being cared of and an inability to function independently. This is a quick, helpful reference guide for you, comparing all the 3 personality disorders we've just discussed, listing their core patterns and symptoms as well as causes. Before wrapping up this video, I want to spend some time discussing important exam tips and common mistakes that students make in their exams. Some high-yield areas or important focus areas for you to study during your exams. Number 1, the bipolar disorder's 2-phase structure, mania and depression. This is a near guaranteed distinguishing question. Causes and symptoms for all the 3 personality disorders are important as well. Case study identification questions mostly come from the personality section, asking you to distinguish between antisocial, avoidant, and dependent personality disorder. So remember to practice this case study questions before your exams. Now, where students lose the most marks or make the common mistakes are that writing symptoms or only causes for personality disorders is usually not enough when both are required. Simultaneously, describing bipolar disorder as simply severe depression without mentioning the manic phase is wrong and will cost you marks. Confusing avoidant personality disorder with general shyness and missing the functional impairment part is also an area where a lot of students make mistakes. So, an important tip to keep in mind is that avoidant personality disorder is not general shyness or introversion. Finally, confusing avoidant and dependent personality disorder with each other is another point where a lot of students I've seen lose marks. So just go back to the slide where we discussed this and it'll be very clear. Finally, what to avoid while studying this chapter. Now, do not study the 3 personality disorders as one list. Use the table that I gave you previously to build a simple list of columns and symptoms and causes for each, so you can retrieve both halves under exam pressure. Do not skip memorizing the manic episode symptoms separately from the depressive episode symptoms, because examiners often ask for one or the other specifically, so you need to be knowing the key symptoms to the T. Finally, do not confuse this chapter's personality disorders with the Chapter 2's personality theories. This is about diagnosable dysfunctional patterns and not general trait descriptions. This is again the part of mixing up introversion with dependent or avoidant personality disorders, so keep those in mind. That's all for today. As always, please do like, share, and subscribe to ACE ISC Psychology for more exam-oriented content and exam tips. In the next video, we will cover ADHD, autism, and separation anxiety disorder, where your syllabus only asks for definitions and symptoms, so this will be a quick video. Stay tuned for the next one.